Good morning, everybody. Welcome to your Grand Rounds. Nice to see everybody this morning. We're excited to introduce our speaker, Dr. Nate Page. Dr. Page went to undergraduate at BYU, where he majored in linguistics. He then completed medical school and his residency in ENT at Washington University in St. Louis. He then went to San Diego to complete his fellowship in Pediatric ENT at Rady Children's Hospital. He then came to the Phoenix area and joined PCMG in 2017. He's currently the acting division chief for ENT here at PCH. This morning he's going to present on surgical management of pediatric vocal fold paralysis. Dr. Page.
All right. I'm happy to be here this morning. Pediatric voice problems are one of my areas of interest, something that I really enjoy. This is a very specific area of that I think overlaps with a lot of different specialties and a lot of what people do within pediatrics. Let me do a quick audience poll. How many of you are pediatric trainees? Okay. And how many general pediatricians? And how many surgeons and the like? And how many I didn't call on? I see a couple of OR staff in the back. All right. Some spubs. All right. So we got a good crowd. And a mixed group. So I'm going to talk about pediatric vocal fold paralysis, primarily unilateral vocal fold paralysis. Bilateral has some different issues that go along with it. That could be a whole talk for another day. And hopefully end about 8:15. I'm happy to answer some questions at the end and see where we go. Let's try this again. So I don't have any financial disclosure. I am going to talk about off-label use of products for vocal fold injection briefly. All right, so when we think about voice problems, this is more what people think about. And so pediatric voice issues don't come up nearly as much. There are, in the adult laryngology group, people deal with singers and professional voice users, and we have a little bit of that overlap in pediatrics, but we're looking at mostly a different crowd. We're looking at kids who have voice that is dysfunctional enough to be impairing their daily activities. So we're going to look at some. There's two reasons that we think about investigating pediatric voice disorders. The first is that a voice problem can be a sign of a disease that requires treatment, as in this case where we have laryngeal papillomas that are on the vocal fold edges and cause hoarseness long before it becomes an obstructive problem. The second reason is because voice changes impact quality of life. So we don't think of that much. You know, all of us have a day where we're a little hoarse, people ask if you're sick, things like that, and it usually doesn't impair you too much. But some of these kids can have significant problems. I want to play a little clip of a kid that I helped take care of. So they sound like Gollum, right? I mean, that's not going to be something that helps you socialize, feel good about yourself in school, things like that. One of the common things we hear from kids, like when I'm playing basketball or soccer, nobody passes me the ball because they can't hear me when I'm yelling that I'm open. So there are little things like that that are a big deal for kids' quality of life. There's some good studies that demonstrate the impact of voice dysfunction on kids. And these are some of the areas that are involved there. Sorry, I've got to point with my pointer here. In a quality of life measurement survey, there was significant decrease in quality of life for kids who had voice problems, particularly in the areas of social, emotional, and physical functional well-being. So it's something that clearly impacts kids when they have voice problems. You all probably hear little kids who are just a little bit rough or a little bit low-pitched, and it's just cute, and it doesn't bother anybody, and those kids are probably okay for most of their life. But as soon as it tips over into the range of the sample we heard, it's a significant change, and that really does impact kids. One of the things that I've noticed from working with kids with voice problems is that they usually don't tell you how much it's impacting them. And one of the problems that we've had a lot is you ask the parents, you know, is this an issue for your child? And they say, no, it really isn't. And then when you ask the kid, you know, does anybody at school make fun of your voice? They go, yeah. Do you get uncomfortable reading out loud in class? Yeah. You know, and they'll answer this question, but they never come to their parents and say, boy, I don't like reading in class because my voice sounds so funny. And so you really have to ask specific questions in that area. Lots of different reasons to have a hoarse voice. Today we're really only going to talk about vocal cord paralysis or paresis. A word on that, I should say. So the title was Management of Vocal Fold Paralysis. So So in otolaryngology, the vocal folds are really the most correct term for vocal cords, and includes the specific areas that we're talking about. However, people mostly use it interchangeably. And I don't want you to feel like I'm being extra pretentious by calling them vocal folds. That's just something that typically we use in our formal discussions of these, and something that I think is appropriate for everyone to understand. Everyone also knows vocal cords are the same fit. You'll hear me slip back and forth. A quick view of anatomy. So normal laryngeal function includes abduction or opening during inspiration and adduction during phonation. So you can see a wide open airway, you see well down into the trachea. During phonation, things close. That allows you to have good vibration of the vocal folds and produce a voice. During normal respiratory variation, you actually also get some natural opening and closing, much more subtle than this. You get a little bit of extra widening during inspiration and a little bit of relaxation during expiration. That's the natural cycle that helps you get a little, decrease the resistance when you're breathing in. So this is a child with a unilateral vocal fold paralysis. And you can see these quick breaths. This is a baby, so they are quick little breaths. But you can see that you've got movement of this arytenoid and this vocal cord, and on the left here, this is completely still. So this is a child with a left vocal fold paralysis. You can also see that that kid has a trach, which is a little more complicated situation. There are quite a few muscles around the larynx that make it seem very complicated, but there's really two things that we care about today. So the thyroarytenoid muscle and the vocalis muscle are muscles that are important for closing the vocal cords and helping produce voice. The posterior cricoarytenoid muscles in the back are mostly responsible for opening the cords to give you that abduction. The problem is that both of those are innervated by the same nerve, the recurrent laryngeal nerve, which means an injury to that nerve can have somewhat unpredictable consequences because you take away the innervation to both the closing muscles and the opening muscles. These are unusual nerves in that they have a very long course. So both nerves come down on the vagus and then have a recurrent section, hence their name, where they loop back up and come along the tracheoesophageal groove to enter the larynx up high, which actually gives you quite a long distance in two different anatomic spaces for these to be injured. So the left recurrent nerve is most commonly injured in large part because of its longer course. It comes well down into the chest, loops around the aortic arch or the ductus, and the right a little bit higher around the subclavian artery. There are some cases where these are not recurrent, that is, they come directly off the vagus, and theoretically those nerves should be much less likely to be injured. There's a lot less space, a lot less area for them to be damaged. So this becomes a surgical issue for a couple of reasons. We're going to talk about surgical management today, but also the most common reason for vocal fold paralysis in kids is iatrogenic, so it's usually surgical. A large portion are idiopathic, and we don't ever get to the bottom of those. So this is an area that we have to consider as we look at where these come from. Most common procedures are cardiac, because we're working in that area around that loop of nerve in the chest. And aortic arch reconstruction of various kinds are by far the highest in terms of the proportion of injury in that population. PDA ligation has been well studied, as that's a common procedure in very young kids. But anything that works around the esophagus, the thyroid, because we're working in that bed where the nerve lives. ECMO cannulation is unusual in that you have essentially equal opportunity to damage the right or left depending on where you put your cannulas. Low birth weight and preterm birth are both been shown to be consistent risk factors for vocal fold paralysis in all of these groups. So a quick look at the types of cardiac surgery that are impacted. So as we said, aortic reconstruction is a big group. But these are from a couple of different studies, and these percentages vary, and they vary in large part based on the population that you're working with. So there are some studies that suggest that higher volume centers that do more cases may actually have a higher proportion of vocal fold injuries, and that is in large part because they're doing younger and sicker kids that are at higher risk. So it doesn't necessarily mean the surgeons are worse or that there are bigger problems, but we're dealing with a challenging population. After 1 year of age, there's good evidence that the risk of injury to the nerve from cardiac surgery goes down considerably. There are a number of issues that are associated with congenital cardiac anomalies, and this is important. Unilateral or bilateral vocal fold paralysis can be identified in children before cardiac surgery. So there can be anomalies in the anatomy that change the function of the nerves as well. Sometimes these are not determined because these kids are intubated very early in life and have their surgery early. And so there are still some areas of research to help determine what the pre-existing rate of vocal cord issues are in those kids. So symptoms can be various. These are the most common things we see. Dysphagia with aspiration, hoarseness, particularly in older kids. In younger kids, you do hear a hoarse cry or sometimes no cry for a period of time after an injury. Stridor and airway obstruction, failure to extubate. Exercise intolerance is something you may hear in an older kid with a vocal cord that doesn't open all the way. Hoarseness is often the reason that kids present, particularly in the older crowd. In our younger kids or in that cardiac population, we're going to see a lot of failure to extubate. We're going to see a lot of stridor and problems after extubation. This is an older kid that we evaluated in the voice clinic previously. And you can hear the...
You feeling, buddy?
After a while. He's trying very hard to compensate by squeezing over his right vocal cord, and he just can't achieve closure. And so you get that very breathy voice, and he can't talk for long enough. And that's a huge impact on kids that are trying to communicate, especially an older kid who's trying to go to school and socialize and participate. So prognosis falls into three categories. So either you can have complete recovery of the nerve, of the function of the vocal cord. You can have incomplete recovery, but get good compensation. So in the end, those two result in the same outcomes, right? You get good swallowing, you get good voice, and everyone's happy. So the only one we really have to deal with is the third group. That's when you have incomplete recovery of your paralyzed nerve without compensation from the contralateral vocal cord, I'm sorry. And so those are the kids that we actually have to start thinking about doing something for. There are different estimates of recovery, and it very much depends on the different population of kids you're dealing with. This is for a group of kids that had had cardiac surgery and were followed over time for, for at least 6 months. They estimated 35% spontaneous recovery rate. And 65% of them had persistent problems. I often tell families to sort of simplify this, you got about a third in each of those categories. So about a third of kids recover completely, about a third of kids will not recover but will compensate well enough to do fine, and about a third of kids we have to think about doing something for. In this study, they had 27% of kids that required surgical intervention, despite the fact that 65% of the kids had persistent vocal cord paralysis. So many of these kids do compensate, and they're able to function quite well afterwards. They even can have completely normal voices, something that you wouldn't even be able to detect once they recover. So here's one study after PDA ligation with a longer period of follow-up. Now this is a completely different crowd than in that previous study. So these are kids that with a mean EGA of 24 weeks. So these are very premature babies. And look at their mean birth weight was 673 grams. This is a very tiny group of kids. Their complete resolution in that group, 3%. So the prognosis depends heavily on the kind of kids we're talking about. So, and this is well known. In these tiny, tiny babies that are having PDA ligation in the first 2 or 3 weeks of life, their risks are very high, although this doesn't estimate the incidence, right? This is just taking the group that had these issues. But they only 2% of these paralyzed cords, 3%, 2 patients of these paralyzed cords actually improved. And of those kids, they had persistent symptoms in this percentage here. Mostly dysphagia was the biggest problem. In that younger crowd, we're not really worried about hoarseness, right? So their cry is a little bit hoarse, but communication is not a major issue. At that point, they're trying to survive. They're trying to feed and grow. And so the dysphagia and aspiration is a much more concerning situation. All right, so there are a number of things we do to work these kids up. All of them need some imaging of the vocal cords. That's really how we make the diagnosis. Most commonly with flexible fiber optic laryngoscopy, which we can do at the bedside or we can do in the clinic. And that's done completely awake with the purpose of being able to watch the vocal cords move, right? We need to be able to see them without anesthesia, without something to compromise our view. Sort of the rule of thumb that we often use is that if you're under anesthesia and you see the cords moving, that's good. But if you don't see the cords moving, you really need to reassess when the patient's awake. You can't diagnose a paralysis when the kid is asleep. So normally we're going to take a look with child awake. Rigid video stroboscopy is a neat tool. That's the image I showed before of that breathy child was a great image quality because we're using a rigid video strobe. The problem with that is that you need an older kid that's cooperative enough to let you do that transorally. So we've done that in kids as young as 6 years old, but I would say in general the kind of 12 and up crowd is where you're going to get those really good pictures. Mostly we do transnasal flexible laryngoscopy. Rigid laryngoscopy and bronchoscopy, as I said, is still a key portion of evaluating this, looking at other problems, looking at signs of aspiration in the airway, et cetera, but it is not our primary method of identifying and diagnosing vocal cord paralysis. Many of these kids need a modified barium swallow because of concern about dysphagia and aspiration, and that can help guide therapy, feeding therapy. It can also help address ongoing issues, adjusting feeds, et cetera. Voice evaluation for the older child where hoarseness or voice quality is the major impact is important. Right now at PCH we don't have any therapists who are trained in voice management. And so that's something that we've been working on since I came, and I'm glad to say that we are very close to opening up our own pediatric voice clinic here as a partnership with Mayo. They have an excellent voice therapist who spent her career in pediatric voice, who will be coming over here to join us for that. And so we're starting to build that program, and hopefully we'll be seeing a lot of these kids through our voice clinic for workup and for management once that's organized in the next few months. Laryngeal EMG is a newer modality. It's not new, it's been around for a long time, as EMGs have, but becoming a useful tool for pediatric vocal cord evaluation in the last few years. Briefly, laryngeal EMG involves putting electrodes into the muscles of the larynx, both those sets I talked about, the thyroarytenoid muscles and the posterior cricoarytenoid muscles, to evaluate the motor units that are going both for the adducting muscles and abducting muscles. So in children, this needs to be done under general anesthesia, you might imagine. In adults, these can actually be done awake in the clinic. But these are typically done along with another procedure, a laryngoscopy or some of the other procedures that we'll talk about later on to help evaluate them. It's very quick. You do need a neurologist who can read those, and Dr. Gerard has been doing a couple with Dr. Nagy. Have you done one as well? Dr. Crockett has done one. So in part, I think the pediatric ENT community is still determining what the best situation is for these. But one of the things that we can do with laryngeal EMG is have some estimate of the prognosis for recovery. And so that's nice if you're contemplating a permanent fix to a problem, if you really know that this is a permanent problem. So if you can do an EMG and determine that there's actually significant potential for this nerve to recover on its own, then you're definitely going to avoid a permanent solution and you're going to wait for that to improve. Typically the improvement for an injured vocal cord will take 6 months to a year before you see that completely recover. And so if they're having ongoing issues, you're tempted to intervene in the meantime. But what this can do is potentially guide us to be able to say, hey, we think this is going to recover, let's do something temporary, versus there's very little chance for recovery, and so we should move more quickly on to a permanent fix for this. So there's a number of management strategies for vocal fold paralysis. Observation is perfect for the kids that are functioning well, have some mild voice issues, are swallowing and thriving, don't have problems with aspiration. And so that's still a very common phenomenon. I would say most of our kids, we start with this. Let's see how they're doing and make further plans. Voice therapy can be very effective in improving quality of voice. The challenge is if you can't really close your vocal cords all the way, voice therapy can only take you so far. You'll still have a gap, you'll still have a breathy voice. And so in some of these situations, therapists try to teach them to use external muscles to try to squeeze down, but that can create some additional problems down the road. And so if there's a large gap, usually the therapists are going to say that's probably not going to get you as far as you want to go. We'll talk about the next three, which are the surgical interventions specifically. There's been a shift in how pediatric otolaryngologists think about these problems and think about these interventions. And this is a fairly recent, recently published survey. And this is a survey of pediatric otolaryngologists with specific interest in laryngeal issues. And so this is a very, very narrow crowd. But what's interesting is this number here at the bottom. In a young child, 22% said that they would immediately move to a laryngeal reinnervation as their first step. 37% they would do an EMG. And it's pretty clear that 10 years ago, those numbers would have been significantly different, and probably still are in the general community. But this is where kind of thought leaders in the field are moving towards, gaining more information from laryngeal EMG and looking towards more permanent procedures to resolve the problems. So voice therapy, as I was talking about, the therapists who want to do voice therapy for kids really have to be, they have to understand children and their parents well, as is true with all pediatric therapists, but you need a child that's cooperative enough to participate. This isn't just the simple therapy that kids do at school, trying to learn their articulation and say R's better and things like that. It takes a lot of cooperation, and it takes some commitment from the parents to cooperate at home. That being said, for a lot of areas of pediatric voice problems, this can have a tremendous improvement for the kids. It can improve their quality of life. It can improve their communication. Vocal fold paralysis is a little bit limited, in part because we're dealing with a crowd. Most of the time, these are very young kids. And we typically say around age 5 to 6 is when we see these kids kind of be mature enough to participate and cooperate. For some of the kids, it's going to be older than that before they're really ready to be able to do enough in voice therapy to see progress and see things get better. Again, as I said before, there's really no change in the function of the cord. They just teach them to kind of accommodate it, teach them different methods for working around it. If there's a large gap, it really is of limited utility. So vocal fold injection has been around for a long time, and using a number of different injection materials, essentially just to provide bulk to the vocal cord, to be able to push it over and narrow that gap, which lets your remaining functional vocal cord close the gap better and get you better quality in your voice. In adults, it can be done through the neck, or it can be done through the mouth. It can be done awake in the office, and commonly is. In kids, that can be done in an older cooperative teenager. I would say that since I've been here, I've done one injection awake in a teenager, and she said, I will never, ever do that again. So I think for the most part, we're going to do these under general anesthesia for our kids. She did fine. She just didn't like it. So these are typically temporary interventions. There are some longer-term injectables. We'll talk about that a little bit. Very safe, very straightforward. The biggest risk in kids is that it's done under general anesthesia, so you need to put them asleep to be able to do it. It improves glottic closure considerably, which can improve the voice and improve swallowing. So for some of these kids that have dysphagia and aspiration, even if their voice is not an issue, injecting can help a lot. We move the vocal cord over, we narrow the gap, they close better, gives them one more protective mechanism. The downsides, again, it's temporary. That's the good and the bad. And potential inflammatory reactions. I'll tell you briefly about the Teflon issue. Teflon, just like the Teflon that coats your nonstick pans, when that was developed in the 60s and 70s and was a miracle application for a number of different issues, people realized that it could be made into a slurry and could be injected for the same reason we do other things, to bulk up tissue. And so that was done fairly widely with fairly good results. Before that, the issues had been, the materials that typically were used were fat and collagen, which requires harvesting tissue from the patient, processing it in some way, and then re-injecting it. And so having something off the shelf that you could inject right away was a great solution. You open the package and you put it in a syringe and you inject it. And so that was a big advantage. However, 30 years later, a number of these people started to develop granulomas from the Teflon. And a granuloma in the larynx, in the very aggressive form of these granulomas, was a significant problem, not only for hoarseness, but became an airway obstructive issue for some of these patients. You develop large masses of tissue in the larynx. And I remember in my training having to do several of these on people where you would go and try to clean out all this granulation, laser the tissue, and pick out little bits of Teflon that had been there for 30 years and for some reason finally start developing this inflammatory process. The reason that I tell you that is not just because it's a neat story, because that makes everyone very concerned about newer injectables that we're putting into children. So the problem is now you have these things that you're going to put into a kid that's going to be around for 80 more years, and it makes people nervous. Do you want to inject something that seems okay right now, but in 30 years might be a considerable life-threatening problem? And so that weighs in on all these different substances that we're using. So from here down, other than fat and collagen, all of these are off-the-shelf products, and all of them were developed for cosmetic purposes. So they're developed to fill in lines and wrinkles and things like that. But as a tissue filler, they also work great for vocal cords. So the reason I put that in my disclosures at the beginning is because most of these have not been FDA approved for use in vocal cords, but have been used since their inception. And there are data in the ENT literature for all of them. Each of them has a different profile in terms of how long they last, how easy they are to inject, and kind of the population that might use them in. Here we use only these two, Prolarin Plus and Prolarin Gel, which are products that, under their previous name, had been FDA approved for the use in vocal cords. That was in 2007. When I was preparing this talk, I decided I'd better verify if the new product is still FDA approved, and I couldn't figure that out. So I have to track down those reps and find out if they still have that. None of these other products are FDA approved, but are used in different centers for those purposes. So these two products that we use here, primarily we're using the Prolarin Gel. The Prolarin Plus is a carrier gel that includes little hydroxyapatite spheres. And the hydroxyapatite is a calcium product that essentially is supposed to create little areas of tissue, essentially of scarring in the tissue, that would allow for a more permanent response. So rather than just the amount of filler you get from us sticking it in, you're going to develop an inflammatory response and get bulk to that tissue that lasts for a really long time. And the company says that it'll last a year. Definitely some people said that this lasts longer. The concern about using it in kids is the Teflon story. So everyone's worried about putting something in that could potentially last a long time and that we're not totally sure about the results. So we're very cautious about using long-term injectables like this in kids. Primarily, we're going to use the Prolarin Gel, which includes that carboxymethylcellulose carrier, but not the little hydroxyapatite spheres, which means that you get a good bulking when we inject it, but no long-term benefit from that. So this typically resorbs over a period of a few months. This is the FDA approval for all of these, for wrinkles and folds in the face. So this is still photos, but I'm see if I can illustrate what these do. You can see, if you look carefully, you can see a little asymmetry here. So where this one is positioned as opposed to where this one's positioned. So this is the left and this is the right. So what we're getting is some movement of that right, although we're not seeing it in our still shot. And the right's opening up, the left is not. What we want to do is bring that left vocal cord closer to the middle so that when the right side closes, you get better coverage there. You get a better closure of the gap. This can show you a little bit off to the side. This has been a long-standing paralysis. So what you see is some atrophy of this muscle right here. So it's normal to have a little gap over here, but this helps illustrate that that muscle has been lost because of long-term denervation of that area. Here's the needle. That doesn't show very well, but here's the needle up at the top. Coming in and injecting lateral to the vocal ligament, and we're trying to push that over to get it into the midline. So this is our afterwards. So if you compare it, the pre and the post here, there's a little bit of gel kind of oozing out. You can see that this is now much closer to the midline. Instead of a little vague concavity, you have a much stronger convexity here, and that's going to provide good closure up in the front. So voice should be improved immediately. And swallowing should be better if that was an issue to go along with it. So that's the standard vocal fold injection technique. So there is lots of literature in the adult population, and there's more and more literature in the pediatric population about the efficacy of vocal fold injection. So in this group, they showed improvement in 24 out of 27 cases in a wide-ranging age group, mean age of 8 years old. One patient developed stridor, and you can imagine that if you squeeze that airway shut, there are going to be some kids occasionally who get some stridor. We haven't had too much trouble with that, but you have to be a little cautious in how aggressive you are injecting, particularly in patients that don't have a great deal of give and might be pushed over the edge. The group, they were using 16 with hoarseness and 13 with dysphagia and aspiration. It felt like they had really good improvement on all of these for a very low-risk procedure. So in general, we see injection, medialization laryngoplasty is the other word for that, as a very effective but temporary fix for vocal cord paralysis. It's excellent for those kids that we expect to see recovery. So a kid with a nerve injury from a surgical procedure, that the nerve is not transected, but that there's been an injury, this is a great solution for them. We buy them a few months, we get them improvement in their symptoms, and then we wait to see if the nerve will recover. So this is a child with a vocal fold paralysis. This is actually a girl with a caustic ingestion who required esophageal replacement surgery. So she, you can hear the breathiness of her voice.
Muy bien.
Yeah.
Good job.
Bajo a alto. Fuerte. Es lo que necesitamos ver. ¿Puedes hacerlo?
So that's her very, very breathy, very weak voice, and that's what she had before the injection. I don't have video of the post, but we do have.
La cucaracha ya no puede caminar porque no tiene otra pata para caminar.
So, and she can sing. So that's, now obviously again, that's a temporary fix for her. And so more will need to be done down the road unless she has recovery, which is possible for her. But just one illustration, that's a very effective procedure that can be done very quickly and easily. Thyroplasty is the second thing on the list. I'll go briefly on this. This isn't used as much. It's a straightforward procedure that's been around a long time in adults. Essentially, you cut a window in the side of the thyroid cartilage adjacent to where the vocal cords are, and you put something in that pushes it over. Lots of different things that have been used. There are some off-the-shelf implants that you can snap in. Gore-Tex ribbon is used to kind of fold into the level you want. The way that that's typically done in adults is that they're done with some light anesthetic. So they actually have a nasal cannula, and after this is all opened under local anesthesia, a scope is put in, and you watch the vocal cords move. You have the patient vocalize while you size your implant. You try to figure out how much closure you want to get in there. And so you have them talk, and you hear the quality of voice they get. When it gets too tight, you're too far, and when it gets too breathy again, you're too loose. And you can adjust it very well and get yourself exactly a comfortable level that they would want. So that makes it a very effective treatment for adults. The other part of that that's important for adults is that adults aren't growing anymore. And so a small child that you could precisely get that in, which first of all you can't because you can't do them under local anesthesia. So you do your best estimate to get it how you want it, but then they grow. And so the chances they would need revision over time to continue to improve their closure. So this is used predominantly for older teenagers who are essentially done growing, that we could get a cooperative patient that this could work on. And in general, it's done fairly rarely for kids. This is, there are a couple of more reports, but there aren't a lot of these done. And so the number of cases reported is pretty low. And people, the pediatric ENTs with a strong interest in laryngology want this to be part of their armamentarium, something they can offer to people, but nobody's doing 50 or 80 of these a year. It just doesn't come up that often. Again, this is a good illustration of using this implant to push over that vocal cord to get the same result that we would achieve from a vocal cord injection. So the last one, which I guess I covered that in my photo enthusiasm. So laryngeal reinnervation is a procedure to actually re-establish the neural input to the larynx. And so it sounds like the perfect fix, right? You injure the nerve, what's the best solution? Well, fix the nerve and get the nerve to work again. It doesn't actually work quite that well. So when when the larynx is reinnervated, you don't typically get that normal motion again. But what you get is really good tone because you establish those muscles. That atrophy that we saw before is restored. So you begin to get bulk of the muscle again, and you get medialization. And so there are a number of techniques. This again, I only listed this reference. This is, Dr. Crumley was at, I think, Loma Linda, somewhere in Southern California. And in the 70s and 80s developed this technique for use in adults. And it took a long time for it to catch on until he demonstrated really good results over time. Once that happened, then it was really slow to catch on in pediatrics, which for a lot of people, myself included, think, why not pediatrics? Who heals nerves better than kids? This seems like the best possible solution for them. And so over time, that literature has been established for pediatric patients, and I'll show you some of that today. The technique that I'm going to describe is a direct anastomosis. It's the simplest to understand. You borrow another nerve from the neck. Usually we use the ansa cervicalis or a branch of the ansa, and you just plug it in end to end to the stump of the recurrent laryngeal nerve. So the nice thing about this, it's permanent. So once you get it established, you get bulk in those muscles, you never have to do anything again. You can do it with an injection, which is important because there's a delay in nerve recovery, right? So we give them an injection that lasts 3 to 6 months while we're waiting 3 to 6 or even longer for that nerve to really heal and be able to provide the result that we want. There really are excellent voice outcomes with reinnervation. The downside, and this is interesting, is that it's an open surgery. That is, we have to make an incision in the neck to find the nerves. I've been surprised at how many of these cardiac patients with ECMO scars and sternotomies and 8 or 10 surgeries under their belt are really excited about this until I say, we're going to make an incision in your kid's neck, and then they're like, whoa, 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 whoa. I don't want to do another surgery like that. We're not going to do it. And so I haven't sorted out the psychology of that, but that really has been a fairly common phenomenon where people say, this sounds great, and then they go like, you know what, we'll think about it for a while. It really is a small incision in the neck. It can be easily hidden, but it's important to some of these people. And so if they weigh the outcomes versus this scar, then really it's up to them. This is always going to be an elective procedure. So the ansa is a nerve that if you do neck surgery, you probably blow through most of the time on your way to the important stuff. So in this case, you're going to see it just outside the carotid sheath on the deep muscles here, on the more superficial muscles. And you identify that nerve and dissect it out. What usually I like to do is I like to find the recurrent nerve so that I can get a sense of the caliber of the nerve that I'm trying to attach it to. There's a lot of variability, and so if you have a great big recurrent laryngeal nerve and a tiny ansa or vice versa, you're not going to get a good fit. And so that helps you determine whether you use the entire stump of the ansa, or if you take one of the branches that goes to the individual strap muscles, that's a better fit for the nerve that you've got. Some have also described a side end-to-side anastomosis for bigger nerves, but if you can get it end-to-end, that seems like the most direct approach. This shows them, this is actually from the University of Iowa, but this shows them after they've anastomosed the nerves. I love the heart that they made out of plastic to demonstrate it. So that's their nerve newly intact and ready to start functioning. This is actually a photo that I borrowed from Dr. Nagy for one of her reinnervations. Here's her recurrent laryngeal nerve here. The stump is tied off, waiting for her to identify her ansa, and this is a branch to the omohyoid muscle. So she determined that that branch was the ideal fit, and so next step is she'll anastomose those together. So sew those two end to end and fill it in. Most of the time they're also going to be injected at that time to give them some short-term benefit while we wait for the long-term benefit of the reinnervation to take place. This was first reported in kids in England in 1993. So that's 20 plus years after it started being used for adults. And the first really big pediatric series, which wasn't that big, but a dozen or 15 kids, came from Marshall Smith in Salt Lake City. He presented that in 2012, and he had ages 12 to 21. And I remember I talked to him after that presentation and said, when are you going to do younger kids? And he said, very logical. I really needed to demonstrate that this could be done in teenagers, and my next step is I'm going to take this to younger kids, and in a few years you're going to see my results from that. And true to his word, he did. This is one from CHOP with a group of kids from age 3 to 16, and they saw tremendous improvement in these kids. In every category they looked at, reinnervation was a better fix than the other techniques that were used to reestablish the voice. So again, this wasn't primarily for dysphagia in this study. This was primarily for voice issues, but they got really excellent results for this. So this continues to demonstrate that this is a great resource. So here's Dr. Smith's study. So he then published a study of 35 children that expanded his previous group, including kids as young as 1. Now, you really aren't going to do kids younger than 1 because typically we're going to wait at least a year after a surgical injury or after an idiopathic paralysis is diagnosed to allow for spontaneous recovery. So if people start having age 0, I think we're going to ask a lot of questions about it. But as early as age 1, a lot of people will say you should wait a little longer for younger kids because there's been some spontaneous recovery seen after 2 years of observation. And so, but most people are going to say by age 2 or 3, after a neonatal type procedure, probably a lot of people would say it's reasonable to consider this procedure at that point. You're not going to get any more spontaneous recovery, and so a permanent procedure is a reasonable fix. As we are adding more and more laryngeal EMG into the mix, we may have more opportunity to look at these and say, we have a better estimate of what that prognosis is going to be and whether there's actually going to be improvement over time or whether we're going to see, we know already this kid isn't going to go anywhere and maybe we can start doing it earlier. There is one systematic review that showed that reinnervation is the most effective treatment. Now take that with a grain of salt because that is a fairly small group of kids. This is not something that has had a large volume of literature published, but in a summary of all of these, references down here at the bottom, they did demonstrate that reinnervation was more effective than the other techniques they had for some of the same reasons we're talking about. In summary, so these are the important principles I want to see. Vocal cord paralysis and other voice problems for kids, I'll add in, can cause significant decrease in quality of life. This is something that is worth being aware of. In the history, particularly in cardiac kids, if you look at how those procedures developed over time and outcomes improved over time, we lost our cardiac crowd in the back now if they're missing this part. But as cardiac surgery improved and more kids survived, then attention got turned to other outcomes. This is very analogous to kind of the hem-onc process, right? So as kids began to survive childhood cancer, we had to start having survivors clinics, and we had to start saying, oh, what do we do with these kids with all the things, the toxic things that we did to them to get them through their cancer, and now we need to address those issues. And so voice problems have become more and more of a concern as these kids are now surviving their congenital cardiac problems, and now they want to say, well, now what else can you do for me? It's not good enough now to say, well, we saved your kid's life, what else do you want? We need to also say, all right, how do we now improve these other aspects of their life? And vocal cord issues, and I should say voice issues, are a really important aspect of their quality of life that can be improved. The second statement here is that there are effective treatment options. I've seen many kids that came to see us for their voice who were essentially told, yeah, your kid's hoarse, but there's really not much you can do about it. And that is simply not true. We have a lot of options available, and we can help most kids with voice problems. We can't always give them a normal voice, and kids with airway surgery and major reconstruction, they're a much more complex crowd that we need to deal with. But children with voice problems that are bothersome, or children that if you heard their voice and felt, man, that would really be bothersome, it's worth a conversation about, because there are a lot of things we can do. Lastly, pediatric voice clinic and PCH. So keep your ears peeled. You're going to hear more about that over the next several months as we get everything lined up and we're able to make those arrangements so that we can bring kids directly and they'd be evaluated by myself and by a voice therapist. And we're establishing protocols to be able to have those kids who need therapy get their therapy here at PCH and not have to be sent out to other places. So in another year or two, I hope to be able to share with you some of the data we've gathered from that and the improvements we've made on that end. So thank you. Dr. Rodriguez.
So, maybe I missed it. You talked about attaching the answer to do you ever try and grab the recurrent laryngeal nerve back yourself or put it in position?
Yes. So if you, especially intra-op, so if the nerve is injured intra-op and you know it's been cut, that's a better solution. So you would put it right back together and try to suture it end to end or potentially put a little cable graft between to hook it together. So in these cases, most of the time the nerve's intact. So, well, I take that back. In most of the cases, you can identify the nerves are intact. In many cases, if it was a PDA ligation, we're only going to operate in the neck, so you're not going to find out if the nerve was transected in the chest. And so we're actually separating it in, we create our own end. We get enough length to be able to use to attach it to the ANSA and take it from there. So always, I would say the nerve to itself is a better answer because in that case, you actually may get some functionality. So because you get the same innervation, you get synkinesis, so you don't always get the abductor fibers to the abductor muscles and vice versa. And so you may get some dysfunctional movement, but you can, in those cases, get good movement of the cord and actually recover function.
If you ever want us to dissect out the recurrent laryngeal nerve, just give it to me.
All right. Well, as we are doing more of these cases, There's lots of us to learn and still figure out. Reinnervation surgery takes about 2 hours. It takes a little bit. You have to sew the nerve under a microscope. That takes a little time. The dissection is usually not too bad unless they've already had neck surgery. So that provides a challenge. And in fact, in a kid who's had neck surgery, we often have to have a backup plan because you don't know if that ANSA is going to be intact or not. Again, it's a nerve that we can identify, but most of us aren't too concerned about. And so if you're dealing with a big tumor or something else in there, you may not worry that much about whether the ANSA is intact. And so when we go back in to do a reinnervation, you don't know what you're going to get. So you have to be prepared with some other options.
Where does the majority of your patients come from? They come from outpatient pediatricians that are just referring for a hoarse voice, or surgery, like say?
So we got two crowds, I would say. So we have our inpatients. Those are going to most commonly be CVICU kids or CVICU follow-ups or other surgical patients with complex surgical problems. And we're dealing with them as inpatients because they're having feeding problems, stridor, failure to extubate, those kind of issues. And so those are dealt with, and those are not kids that are going to get a reinnervation, right? Those are kids that we're dealing with an acute problem right now. How do we help fix this situation? The second group are the more elective kids. So those are the kids that come in for kind of routine voice problems. And I would say most of the time, those are, again, cardiac kids are our most common crowd, although we have a mix. And so we get them from cardiology or we get them from their primary pediatricians. What I think is important from our standpoint as an ENT division, now that we're here established, is helping educate everybody to know what's going on with that. Because what I see is I see a lot of referrals from the same handful of cardiologists and none from a lot of the others. And I suspect that it's not that they have a much higher incidence of vocal cord paralysis in their population, but that they think a lot more about the voice issues and what to do with them. And so I think in large part it's just us helping everybody know, hey, we actually have something. I know that when I came, my senior partner in my practice had been advising all the patients, I want you to come every year for me to scope and look at the vocal cord, but we're really not going to do anything about it. And so unfortunately that misled a lot of people, because after a while you're like, why do I keep going back every year if you're never going to do anything about it? And so some of those families just fade away. And so we actually get referrals now of kids who are 16 years old and had their heart surgery when they were an infant, and now they're begging to say, hey, somebody told me that you might be able to do something about this, and they want to have something fixed. Dr. Nagy had actually given me a nice voice sample, but it was really long and it included a lot of interviews, and I'm not good at editing that stuff yet. But for a teenage patient of hers that had a long-term paralysis and got a reinnervation, did very well. In fact, her favorite thing, I should have told this before, but my favorite thing is that we measure with quality of life scales, and we use special instruments to measure acoustic parameters of the voice and all these things. When Dr. Nagy asked the patient, is your voice better? And she said, yeah, Alexa can hear me now. So it's all about, the practical aspects of your life, right? Can my friends hear me on the phone? Can Alexa hear me when I tell her to do stuff? That's what's important. So yeah, those kids may not have a normal voice, but that's a big difference when you can now communicate. And her family said, hey, now we can hear her. Now when she talks to us, we don't have to turn off the TV or whatever we're doing, because now she has enough projection for us to be able to get that from her. Kids don't talk on the phone anymore, so it wouldn't matter. She would just text everyone. So that's a great question. So we don't use ultrasound a lot for that thing, but there are some institutions where they use ultrasound very aggressively for a lot of different things. You can see vocal cord movement with ultrasound. I would not say I'm an expert in that by any stretch, but I know that that's been documented, so you could actually watch the cords move and get some sense of paralysis. You got to have a kid that you can hold still enough to monitor the vocal cord movement, but we haven't done that. So what's your interest in that area? Yeah. No, I think you're right. That's good thinking. And ultrasound can be used for a lot of things in the neck, especially in infants, because you can get, there's not that much depth of tissue, so you can really get all the way in to the air column in the larynx and see a lot of things. So good, maybe that's our next thing to tackle. Yeah, there are different crowds. Some people tell the people not to talk, excuse me, not to talk for 24 hours or something afterwards. There's not really any data that say that it has to be. So normally it's a quick procedure of maybe 15 minutes under general anesthesia, so they recover for an hour or so. They go home, take it easy that day. By the next day, they're back in action, back to school, back doing their thing. Usually no restrictions at that point. The voice changes a little bit. You'll get, often we over-inject a bit, so you get a little bit more tightness to your voice right afterwards because it's going to settle back a little bit when the swelling goes down. And then they get their best quality voice after that, maybe a few days later as things settle down. All right. Thank you very much.